Bismillahirrahmanirrahim. Today the world is the prisoner for the believer and paradise for the introduction. Today the topic of presentation is introduction to the epidemiology. I am Dr. Iqbal, PGR. Learning objectives. By the end of the session, learner will be able to trace the history and evaluation of epidemiology from ancient time to the modern era, define epidemiology and articulate its core aims, describe the major epidemiological approaches and fundamental principles, define and apply common epidemiological terminology and measure, explain the levels of prevention using the natural history of disease, quantify the disease burden using the standard epidemiological measure, systematically investigate epidemic or outbreak using the standard approach. So first we will discuss the history and the background of epidemiology. Definition, the study of distribution and determinant of health states or even in a specified population and application of this study to control the goal of health problem. It includes distribution, determinants, health state and application. Distribution discuss the who, where and when, include person, place, time. Determinant include why and what causes. Health state discuss the disease, injury, disability, and death. And application include control, prevention, policy, and programs. So epi mean upon or among, demos mean the people, and logos mean the study or the science. Epidemiology is not just about the epidemics; it compresses all health-related event, disease, injury, disability, wellness, and in population. Epidemiology is the cornerstone of public health and preventive medicine. It provides the scientific basis for policy, planning, and clinical decision. So it is described as the basic science of public health, different from the clinical medical medicine, and focus on the population, not individual patients. So, historical milestone in epidemiology in 460 BC, Hippocrates on air, water, and place. In 1662, John Grant, Bills of Mortality, Vital Statistics. In 1747, James Lind, Scurvy Control Trial. In 1796, Edward Jenner, Smallpox Vaccination. In 1980, in 1854, John Snow, cholera and Broad Street Pump. In 1950, Dole and Hill, Smoking and Lung Cancer. And in present, molecular and digital epidemiology. So John Snow, the father of modern epidemiology, the Broad Street cholera outbreak, London, 1854, 500 plus deaths in 10 days in London. Snow mapped cases door by door by the spot map technique, identify the Broad Street water pump as a source of infection. So remove the pump handle and stop the outbreak. Prove that the waterborne transmission of cholera achieved without knowledge of germ theory. So it is a landmark of observational field epidemiology. Methods which are used export mapping, case counting, case interview, and comparison group. Snow's legacy provide epidemiology work without lab science, set template for outbreak investigation, and it is used globally today. So 19th, Goldberger provide plague as a nutrition, not infectious. In 1948, Birmingham Heart Study begins landmarks. Cardiovascular heart, in 1948, WHO established global health surveillance era began. In 1950, Dole and Hill link smoking to the lung cancer. In 1955, polio vaccine trial, which is the largest RCT in history. In 1976, Legionnaires' disease modern outbreak investigation template. In 1981, AIDS epidemic. In 2000, genomic epidemiology, molecular surveillance emerged. In 2020, COVID-19, which is the real-time epidemic. Next is epidemiology in Pakistan and the low-middle income countries. Historical development in Pakistan. Pakistan Bureau of Statistics and Vital Registration post-independent 1947. Field epidemiology and lab training program established in 2008. National Disease Surveillance System under NHSRC. So the key achievements are expanded program on immunization, polio eradication program, dengue surveillance and control program. So current epidemiological priorities, the double burden, high communicable diseases plus raising anxieties, climate change and emerging vector-borne diseases like malaria, dengue. In COVID-19, the small hepatitis B, C elimination program. Next is aims and uses of epidemiology. So the core aims of epidemiology are describe health, which characterize the distribution of disease health in population by person, place, and time. Second is explain causation, identify the risk factor, determinant, and causal mechanism through the analytic study. Third is the predictive occurrence, forecast future pattern, risk, and burden to plan health service and resources. Fourth is control disease, evaluate intervention, prevention strategies, and health program for effectiveness. Fifth is evaluate service, assess the healthcare delivery, screening program, and public health policy impact. And the sixth one is integrate with clinic, lab, social data for a full account of health problem. Next is the uses of epidemiology. Morrison, 1957. Community diagnosis determine prevalence, incidence, severity, distribution of the disease in a community. Historical study understand the past trend to predict the future needs. Working of health services assess the adequacy, equity, effectiveness of the healthcare delivery. Fourth is the individual chances and risk. Quantify individual probability of developing disease. Identification of syndrome cluster symptom to define new disease entities and classify conditions, completing clinical picture, understand full disease spectrum from mild to severe. Last is a search for cause, identify the determinant and causal mechanism through the observational and experimental studies. Next is the epidemiological approaches and basic. Classification of epidemiological study. Epidemiology include descriptive, analytic, and experimental study. Descriptive study: who, where, when. Include case report, cross-sectional study, and ecological study. Analytics include case control, cohort, and observational study. Experiment include RCT, field trial, community trial, and natural experiments. Descriptive epidemiology, person, age, sex, race, occupation, socioeconomic status, marital status, lifestyle, who gets the disease, place, geographical variation, urban, rural, country to country, where does the disease occur, time, is secular, long-term trend, cyclic pattern, epidemic curve, seasonal variation. So it show when tool, which are used for section study, ecological study, and case reporting case series. Cross-section study, which is a prevalence study, measure the prevalence, association, and perspective. Ecological study group as a unit of analysis, study to ecological fallacy. Case report, detailed description of single case, hypothesis generation, not casual. So the purpose of this is to generate the hypothesis to test by analytic studies. Analytic epidemiology include cross-sectional study, case control study, and cohort study. Cross-sectional study, exposure and the disease measured simultaneously. Good for prevalence. Hypothesis generation cannot be established temporarily. It measures the prevalence ratio and the odds ratio. Case control study, which is the prospective approach, start with the case and control, look backward at the past, exposure best for the rare diseases and the outbreaks investigation. So a measure of odd ratio. So hard study, which is can be the prospective and the retrospective, follow the exposure and unexposed group forward in the time to compare disease incidence. So it is the gold standard observational study. Measure relative risk. Next is the experimental or the interventional epidemiology, randomized control trial, which is the gold standard of evidence. Participants randomly allocated to the intervention and the control group. Double blinding RCT preferred, minimize the measurement and performance bias. Outcome measure include efficacy, relative risk ratio. Field trial conducted in the community setting on the health individual at risk. For example, polio vaccine trial in 1954, SPP vaccine trial. Community and cluster randomized trial intervention applied to the entire community. Randomization by cluster. Example, water fluoridation, salt iodinization, and insecticide-related bed net. Natural experiment include investigator does not control exposure, exploit naturally occurring variation. For example, snow pump handle, polio change, and migration study. Next is the epidemiological causation, Grand Hill criteria. It includes strength, consistency, specificity, comparability, biological gradient, possibility, coherence, experiment, and analogy. Next, we will discuss the common terminology, fundamental population at risk. Group of people who are susceptible to or at risk of developing the disease under study. The denominator for all the rates. Case definition standard set of clinical, laboratory, epidemiological criteria to decide if the person count as a case. Suspected, probable, and confirmed. Sensitivity versus specificity. Used consistently through an investigation. Epidemiological triad include agent, host, and environment. Agent include biological, chemical, physical, and nutrition. Host include age, sex, immunity, genetic behavior, and nutritional status. Environmental condition include physical, biological, social, and cultural. And other key terminology include cohort, group sharing, common characteristic, incubation period, time from exposure to the symptom onset, latent period, time from exposure to the detectable infection. Next is incidence and prevalence. Incidence, new cases is defined population over a period. Incident rate is equal to new cases divided by population at risk multiplied by constant. Attack rate is equal to cases divided by the population exposed multiplied by 100. Secondary attack rate, cases among contact divided by the susceptible contact multiplied by 100. Reflect risk of developing disease, useful in identifying the cases, evaluating new intervention. High incidence is equal to active transmission and divided by spread. Prevalence is all existing cases old plus new at the point divided by the period. Point prevalence, cases divided by population multiplied by 100. Period prevalence, all the cases during the period divided by the population multiplied by 100. Prevalence is equal to incidence multiplied by duration of disease. Used in resource planning, measuring chronic diseases, high prevalence is equal to long duration or high incidence. Next is the measure of association and impact. Relative risk formula of relative risk is in incidence exposed divided by the incident unexposed. Relative risk is equal to 1, show no association. Relative risk greater than 1, show the positive association. Relative ratio less than 1 in show negative association. Odd ratio of the exposure in the cases divided by the odds of exposure and control. Approximate RR when the disease is rare. Odd ratio is equal to 1, show no association. Attributable risk, incident exposed minus incident unexposed. Absolute excess risk due to the exposure, measure excess risk is exposed. Next is population AR. Formula of this is total incidence minus by the incidence unexposed divided by the total incident multiplied by 100. For percentage of disease in the total population attributable to the exposed guide prevention priority setting. Next is the common mortality and morbidity rates. Crude death rate, formula total death divided by the mid-year population multiplied by 1000. Case specific mortality rate, death from the specific case divided by the mid-year population multiplied by 1 lakh. Case fatality rate, death from the disease divided by all the cases multiplied by 100. Infant mortality rate, death less than 1 year divided by the live birth multiplied by 1000. Neonatal mortality rate, death less than 28 days multiplied by live birth into 1000. Maternal mortality ratio, maternal death divided by live birth into 1 lakh. Population proportional mortality ratio, death from the causes divided by the total death multiplied by 100. Standardized mortality ratio, observed death divided by the expected death into 100. Next is the screening and the diagnostic parameter. Sensitivity, ability to identify true positive. It is true positive divided by the true positive plus false negative. Used when missing diseases costly. Specificity, ability to identify true negative negative divided by the true negative plus false positive. Positive predictive value probability disease is present when disease positive test. Formula of total positive predictive value is true positive divided by the true positive plus false positive. Negative predictive value, probability of disease absent given test negative. Total negative divided by the true negative plus false negative. Positive predictive value and negative predictive value are affected by the prevalence. Sensitivity and specificity are not. Next is epidemic, occurrence of disease in excess of expected frequency in a community or area. Endemic, a habitual presence of disease in a geographic area at the predictable rate. Pandemic, worldwide spread of new diseases, for example, COVID-19, herd immunity, indirect protection when the sufficient proportion is immune. Sporadic, which is occasional and irregular occurrence without definite pattern. Cluster, aggregation of cases in time or place in a unusual number. Incubation period, time between the exposure and the onset of symptom. Latent period, exposure to the first detectable biological change. Generation time, average interval between the infection and the onset. Basic reproduction number, RO, average new cases generated by one uh, uh, infectious person is in fully susceptible population. Next is bias, confounding and fact modification. Bias, which is a systematic error, uh, includes selection bias, non-representative sample information or the measurement bias, error in the data collection, recall bias, cases remember exposure better, observer bias, interviewer aware of the case, exposure status. Next is publication bias, and so the prevention can be achieved by careful design, blinding, standardized tool, confounding, a confounder variable association with both exposure and the outcome, not on the causal pathway, control, matching, prescription, randomization, stratification, and multivariable effect. Effect modification effect of the exposure differ by the level of another variable. Example, age confound alcohol CVD's association. Next is epidemiological surveillance. It is defined as ongoing systematic collection, analysis, and interpretation of the health data, followed by the dissemination and use for public health action. So the type of surveillance include passive, active, sanitary, and syndromic. Uses are detect the outbreak early, monitor disease trend, identify the risk group and the at a risk area, evaluate prevention program. Pakistan IDSR, Integrated Disease Surveillance and Response Framework, WHO, AFRO model. Next is the level of prevention, natural history of the disease, the progression of disease in an individual over a time without intervention. It includes susceptibility, no disease yet, risk factor and susceptible present agent, host, environment in a dynamic interaction. Subclinical cases, which is pre-pathogenesis, disease began at the biological at a cellular level below threshold of the symptom detectable by the screening test. Clinical disease, sign and symptom merge, complication may develop and diagnosis possible clinically. Resolution, fully recovered disability, chronicity, carrier state, or death. Next is the level of prevention, which include primordial prevention, pre-disease era, socioeconomic and lifestyle factors, primary prevention, pre-pathogenesis by vaccination and health education. Secondary prevention can be achieved by early detection and screening and early diagnosis. Tertiary prevention, disease onset and it can be achieved by the rehabilitation and disability limitation. So primary prevention include health promotion and specific protection. Health promotion, action from the whole population regardless of risk, health education, health literacy program, adequate nutrition, housing, sanitation, physical activity, recreation promotion, occupational health and workplace safety, genetic counseling, social welfare services. Specific protection directed at specific disease immunization, chemophylaxis, for example, malaria and TB, meningitis, occupational safety, include personal protective equipment, dust mask, food fortification, salt ionization, and floor fortification, vector control by net, bed net, indoor residual spray. Uh, Example, in Pakistan, EPI, PCG, OPP, malaria, measles, rubella, hepatitis B, typhoid, pneumococcal, retrovirus, and HPV. WASH program for diarrheal diseases prevention, LHW program, salt ionization, feed floor fortification, National Tobacco Control Program. Secondary prevention include early diagnosis and prompt treatment. Early diagnosis include direct disease before a total symptom, for example, mass screening by pap smear and mammography, selective screening, opportunistic screening, case finding and contact tracing, and periodic health examination. Prompt treatment include hard progression once disease detected, treat early to prevent the complication, prevent transmission, shorten the infection period, improve diagnosis and quality of life, for example, TB, HIV, ART, initiation. Next is the tertiary prevention and rehabilitation. Goal is to minimize the disability and maximize the function in those who already have established the disease. Disability limitation, adequate treatment to arrest the progression of the established disease, prevent complication and sequel. Regular monitoring, for example, HbA1c in diabetic patient, echo in heart failure patient. Rehabilitation in four-step medical, restored the maximum physical function, social reintegration into the society, adaptation of living environment, vocational return to the productive work, job retraining and sport employment, and psychological, mental, and emotional recovery. Example include physiotherapy after stroke, prosthetic and orthotic cardiac rehabilitation program, DOT plus, dialysis program, psychiatric daycare unit. Next is primordial prevention. The primordial prevention can be achieved by prevent the emergence of risk factor before they develop into the population. Target socioeconomic and the environmental condition that give rise to the risk factor, prevent the precursor of the risk factor. Example, preventing fast food culture and hereditary life from beginning for becoming the normalized tobacco advertising ban before smoking rate rise in population. Relevance to Pakistan National Tobacco Control Policy, National Dietary Guideline and Physical Activity Campaign for Youth. Next is disease burden. So it is defined as the total impact of disease on population, mortality, morbidity, disability, and economic cost. Evidence by measure burden, evidence-based priority setting in the public health and health policy, equitable allocation of healthcare resources and funding, valid comparison across the region, country, and over time, monitoring impact of prevention and control program. So the key measurement of burden by mortality rates, morbidity, year of life lost, year lived with disability, disability adjusted life year, quality adjusted life year. So disability adjusted life year is equal to year of life lost plus year life lived with disability. Year of life lost due to premature death. Year of life lost is equal to number of deaths multiplied by standard life expectancy at the age of death. Year lived with disability due to non-fatal outcome. A year lived with disability is equal to incident case disability weight into average duration of disability. Next is the global and the Pakistan disease burden. 55 million global deaths annually, 74% death from NCD, 3.7 billion by disability adjusted life year globally, and 10 million due to TB death annually. Double burden, high communicable diseases plus rapidly rising NCDs. Fifth highest TB burden globally, greater than 6,20,000 incidents per year. Hepatitis C prevalence approximately 4.7 among the world's highest, and hepatitis B 4.3. NCD mortality 58 approximately of the total death. Infant mortality rate 55.7 per thousand live birth. Under 5 maternal mortality 75 into 1,000. Malnutrition 40% in less than 5 years. Dengue endemic in Pakistan, Khyber Pakhtunkhwa, malaria high burden in Balochistan and FATA. Next is investigation of an outbreak. Type of epidemic, common source, all which point all exposed at the same time. Continuous ongoing exposure to common source, contaminated water supply. Duration is greater than 1 incubation period. Next is propagated person to person, successive wave of the cases each generation. A mixed epidemic start as a source, common source, and spread person to person. For example, Shigella, which spread through the fecal, which is this is the curve showing point source, continuous source, propagated source, and intermittent source. Next is outbreak investigation. First, confirm the existence, verify the diagnosis, rule out the pseudo epidemic, and check reporting system. Case reporting standards, criteria, clinical, lab, epidemiological. Third is find and count case, active case finding, create the line listing with person, place, time. Next is describe person, age, sex, occupation, risk, behavior. Describe time and place, sport map, epidemic curve. Six is develop hypothesis, probable source, vehicle, mode of transmission based on descriptive data. Next is test hypothesis by analytic study, food, specific attack rate, statistical test. Control measure implement immediately, communicate finding preliminary and final report. And last one is the improve surveillance, strengthen the reporting, update case definition, revise protocol to prevent recurrence. Next is the epidemic curve. What is epi curve? Tell us curve pattern type of epidemic. Point source sharp, well propagated multiple waves. Peak estimate exposure data. Width of the curve suggests the range of incubation period. Outliner in the index case with the usual or the earlier exposure. Constructing the epi curve, x-axis date, time of symptom onset, y-axis number of cases, time interval 1 by 3 to one full incubation period. Next is the common pitfall to avoid use report data instead of onset data. Too wide or too narrow time interval obscure the epidemic pattern, not distinguish probable versus confirmed cases. Next we come to the MCQs. During an outbreak, our team identify the case and then select the control, assess the prior exposure to contaminated food, which where is of infection is most appropriate. A, relative risk collected from the incident proportion. B, attributable risk collected from the cohort comparison. C, odds ratio calculated from the exposure frequency. D, hazard ratio calculated from the survival analysis. E, prevalence ratio calculated from the cross-sectional data.
C.
Yes, C is the right option. C is the right option. MCQ number 2. In an epidemic curve, multiple peaks occur at the regular interval. Most strongly suggest A, continuous common source exposure from the environment. B, point source exposure affecting all individuals equally. C, propagated spread through the person-to-person transmission. D, mixed epidemic with both source and propagated spread. E, sporadic cases occurring due to unrelated exposure. So C is the right option. MCQ number 3, a screening test has high sensitivity but low specificity. Which of the following outcome is most likely? A, high number of false negative among test individual. B, a high number of false positive among screen population. C, high predictive value regardless of the disease prevalence. D, low detection rate of the two cases in early disease. Low ability to detect disease in an asymptomatic subject. So B is the right option. MCQ number 4. Which of the following best represents secondary prevention in the community? A, promotion of healthy diet and physical activity program. B, immunization against communicable diseases in children. C, early detection of hypertension through screen cam. D, rehabilitation of stroke patient with physiotherapy. E, implementation of policy reducing tobacco advertisement.
C.
Yes, C is the right option. MCQ number 5. In an outbreak investigation, viewing the source of infection before analytic confirmation reflect which principle? A, ethical obligation to delay action until hypothesis testing. B, priority of control measure over complete investigation. C, importance of statistical significance before intervention. D, requirement of laboratory confirmation for all decision. E, dependence on external agencies before local response.
B.
Yes, B is the right option. MCQ number 6. Which of the following fulfill the most essential Bradford Hill criteria for causality? A, strength of association between exposure and the outcome. B, consistency of the finding across the different populations. C, temporality of exposure for C, disease occurrence. D, biological possibility supporting the relationship. E, dose response relationship between risk and disease.
A.
C.
Yes, C is the right option. MCQ number 7. A public health officer uses daily adjusted life years to assess the disease burden. What does one day daily adjusted life year represent? A, 1 year lived with disability without mortality. B, 1 year of life loss due to premature mortality. C, 1 year lost of healthy life due to disease. D, 1 year gained due to effective intervention. E, 1 year of incidence adjusted for population.
C.
Yes, is the right option. MCQ number 8. During an outbreak, sudden sharp rise and fall of the cases within one incubation period is observed. The pattern most likely indicate A, single exposure affecting the population at one specific time. B, continuous exposure from contaminated environmental source. C, person-to-person transmission across the multiple generation. D, mixed epidemic with initial and the secondary transmission. E, sporadic cases occurring independently over long duration.
A.
Yes, A is the right option. MCQ number 9. A public health intervention aimed to prevent the development of risk factors such as unhealthy diet and sedentary life. This is A, secondary prevention targeting early disease detection. B, tertiary prevention focusing on rehabilitation services. C, primary prevention through specific protection measures. D, primordial prevention through targeting upstream determinant. E, clinical prevention through hospital-based intervention.
B.
B.
Yes. E is the right option. MCQ number 10. Which of the following measure is the most appropriate for comparing risk between exposure and unexposed group in a cohort study? A, all should derive from the exposure frequency. B, relative risk calculated from the incident data. C, prevalence ratio from post-sectional data. D, attributable risk percentage for population impact. E, case fatality rate indicating disease severity.
B.
Yes, B is the right option. So this is the answer key. This is the key references. This is a YouTube channel where the recording of this presentation will be uploaded. And thank you.
Thank you